Thanks everybody for joining the webinar. This is Building the Patient Experience Using Outcome-Based Principles. And why don't we move on to the agenda slide? So you can see our agenda here. Topics revolve around how to design the best experience for patients, sites, and researchers to get to the outcomes we want. You can see we've got a packed agenda here, and I've got two great speakers joining me today. So thank you, Steve, and thank you, Kamalia, for joining. We have Steve Wimmer, Director of Partnerships at 1N Health, and we have Kamalia Sazali, Senior Product Manager at Obvio Health. And I am Andy Lippitz. I'm the Senior Director of CRO Partnerships at Castor. So hello, Steve. Hello, Kamalia. Thanks for joining.
Hello.
Hey. All right. So why don't we get started and move into a quick little overview topic here. So a lot of what we're going to talk about today is around decentralized approaches in clinical research. And a lot of the innovations in the last couple of years have been around decentralized approaches. So this has become a bit of, it's one of those topics where if you ask 10 people, what is a decentralized trial, you get 10 different answers. I think it kind of helps to get us grounded on what are we talking about today with a lot of the principles we're going to discuss. So the graphic here is pretty simple. So on the left, it's kind of a spectrum. Traditional trials, this was majority of trials for a long time. Patient travels to the site for all visits. There was kind of this vision for fully decentralized trials and was necessary during a lot of the pandemic, where patients can participate from a trial from anywhere, from their home, but do not need to go into the clinic. But the vast majority of what we're seeing now is a hybrid decentralized approach. And this means some visits, patients can participate outside of the clinic. And this may mean that they have an option for visits, 2, 5, 6. They can have a nurse either come to their home or they can go to the clinic, or there's some telemedicine available, something like that. Those types of approaches are what we're primarily seeing, and that's what kind of fits best for both researchers and patients and makes this stuff possible. So just to get started, I think it would be helpful if Kamali and Steve, maybe you can give some examples of some projects you've worked on recently that kind of fit in this this hybrid world. So why don't we start with Kamalia? Give a little color to this.
Yeah, sure. I think you covered it well. Obviously, for the purposes of this conversation, we're really talking about the two sections on the right. So for me, a fully virtual study means utilizing a virtual site team, so not a brick and mortar site. Studies where the patient never steps foot in a site or in a research location. And then on the other side of the DCT spectrum, it's, like you said, a hybrid study being run by a brick and mortar site, but introducing some more remote components, really looking to reduce those site visits. And then there's just a ton in the middle. I think, speaking to what you said before, everyone has a slightly different definition of what this looks like. And I think that's because there's a bit of a gray area there. So I think an example of a place in the middle would be still utilizing a virtual site team, maybe not having a brick and mortar site, but requiring regular blood draws at a local lab. So in that sense, there's not a site running the study, but there's still face-to-face responsibilities from the patient. I think that kind of runs that spectrum of fully virtual to hybrid.
Nice. Yeah, thank you. And Steve, how does this look from your perspective?
Yeah, so 1N Health specifically does patient recruitment. So I think that's the area I'll be able to speak to most clearly. And for us, there is just a really huge gap between being forced to recruit in specific geographies, depending on how intense the study is. Maybe you can go 25, 50, 100 miles outside of the study site, and then opening it up to the entire country, whether that's the United States or whatever country you're operating in. Makes a radical difference in terms of speed and accessibility to different patient populations. So I think we're going to speak to one later, but Kamali and I had the pleasure of working on a study together that was fully decentralized, and the results were really incredible. So from a patient recruitment perspective, specifically in enrollment, that gap between traditional and hybrid really is the question of, are you accessing 10% of the population, or are you accessing 95% of it? And it really does have a transformative impact on enrollment timelines.
Yeah, that's great. And Steve, you've just reminded me that I've violated the #1 responsibility of a nice host on a webinar like this. And I did not do introductions at the beginning. So I think that would be really helpful for the audience just to know where we're coming from. So apologies, but let's quickly just kind of introduce ourselves and our background. So Steve, you just partially did it. Do you have anything else to add about kind of what you
sure. I'll just say that I'm coming to the clinical research world. I've been in it for about 3 years, but I'm coming from a background in e-commerce, so direct to consumer brand marketing. And one of the reasons I was hired into this role is because there is some overlap. One in Health specifically uses digital channels to find people for clinical research. And so I really spent a lot of time thinking and working on how do we use the internet to get people aware of and participating in clinical research. And the mechanics of that are not so different from making them aware of and buying a product. I will say that healthcare, in this country at least, is a consumer industry. People have options. They get to pick, for the most part, what they're doing. And so part of our job is making clinical research a very attractive option to them so that they will pick it. And that's what we're here to do. And that's part of why we love DCTs.
That's great. That's great. Thank you. And Kamalia.
Yeah, so I'm on the other side of things. So I've been in clinical primarily for about a decade now. I started in oncology, working at a nonprofit in Boston. So mainly working as an extension of the NCI, developing and conducting really site-based trials. I left there to get my MPH, and then I joined Avio right after that, Avio Health, in 2017. And I actually started here working exclusively in clinical operations, but I was very attracted to the technology side of things, pretty immediately drawn over there. So I've been slowly making my way in that direction over the last few years, and I moved into product recently, where I'm a senior product manager.
Okay, good, thanks. Yeah, and again, I'm Andy Lippitz, and I've been in the clinical research world for about 20 years now, and my background is working at large CROs, but Castor is a technology provider for decentralized trials and data capture. We really are just focused on technology and kind of focused on how do we create the best user experience and how do we promote interoperability. And so that's the angle we're coming from today. So, all right, we're caught up. Good. So the first topic here is we want to get into is one of the things that is sort of widely known, has been an issue for a long time, is that clinical trials are so important to advancing healthcare, yet it's really a challenge to make patients aware, to even raise awareness of the trials, and to create an experience that patients want to participate in. So first question for the group is, how do we do this? How do we encourage more people to participate in clinical trials? So I will start with Steve on this one. What are you guys working on that encourages patients to participate?
So I think we have a slide that's next that kind of uses our patient funnel model. And the biggest thing for me is that I think we need to be intentional about the way that we're messaging the clinical trial opportunity to folks. So I see some things that are really well-intentioned coming from major pharma sponsors that say, hey, we are looking for clinical trial participants. Click here to see if we have one for you. And most people who are on their lunch break on Instagram are just not really in that headspace. There's a few patient populations who are, rare disease, something like oncology, where they're really aware of their status as a patient. But most of the people who are using the internet are not there to find clinical studies. So messaging around them needs to be more about you, the patient, and what's in it for you. So instead of saying like, hey, we have a bunch of clinical trials, maybe you could fit one of them and help us out. It's going very specific and saying, hey, if you have this TA, there might be an option for you that is better than what you're currently dealing with. And the reason I love the internet is that everyone is there. So there's not really a demographic that you can't find using the internet. And if we've managed to deploy a DCT so that we have access to the entire population, we can now find the people we need for our studies, both just the straight up raw numbers, but also potential diversity requirements, ensuring that we have a representative patient population. So I think the biggest thing is figuring out how to craft messaging that appeals to the patient and answers the question, what's in it for you, the patient, rather than what's in it for me, the sponsor, which is getting my data, getting my drug across the finish line. Because people aren't really interested in that. They want to know what's in it for them. And I think just that shift in messaging is a big part of why we've been able to see a lot of success in these digital channels over the last couple of years.
That's great. That's great. Appreciate that. So Kamalia, how about you? What do you guys? Go ahead. Go ahead.
Yeah. No, I think just kind of building on what Steve said, it is about appealing to the patient. And I think a big way that you do that is thinking about reducing the patient burden. So when we're starting to make something remote or introducing remote components, not just for recruitment, but for the study as well, that starts to do that. It reduces patient burden. And I think that's part of what can encourage people to become more likely to participate in clinical trials. So if you're reducing the number of visits, reducing the time in clinic for potential patients, that translates to not having to take time off from work, not having to commute long distances to the site. I think that's a big one, and it makes it a little bit more attractive. I think it really, to me, the kind of old school study has this, there's a concept around it of it being a huge time commitment. So I think, again, as you start to think about things becoming a little bit more remote, study participation becomes more convenient. It means that patients can take part in studies without it being like a real inconvenience in their day-to-day lives. So that's kind of the concept that we try and take to our studies. And I think we're showing an example here. It's a women's health study that we worked on recently on urinary incontinence. So we actually started working on this project before the pandemic started. It started out as a hybrid study, but given that sites were closing down or couldn't accommodate the study itself, we actually had to pivot to running it fully virtual. And a big thing that we noticed with this project, and really with a lot of our fully virtual studies, is that the virtual site component was a real game changer. So having site staff readily available to patients to answer questions and readily available through mechanisms that the patients were used to using. So chat was a big one, but also just phone calls. That really helped patients feel supported and engaged, which I think is a big piece to wanting to participate in a project. But then it also helped us resolve issues and questions really quickly. So not having those ad hoc site visits, waiting several weeks to go to a site visit, it allowed us to be proactive in supporting patients through their journey. And you'll see here, I think that really translated to things like higher compliance, higher retention, in the end, hopefully better data. But really kind of reinforcing that we need to make sure that the patients feel supported and engaged. So by reducing their burden, but also still allowing them to feel like they're part of a project, I think that's a way to go back to Steve's point to make this more appealing or more attractive to a potential patient.
Oh, that's great. That's great. Some of the comments are fun on the side here. So where was this from? I assume this is part of the outreach campaign that some of these were collected?
Yeah, so these were comments on the study ads themselves. Most of these are coming directly from Facebook. And yeah, one of the things we really advocate for is leaving the comments on. There's a general consensus that if you have the comments off, you're shady and untrustworthy. So we've had to make that case a few times with sponsors, just because it can be dicey to let the public just kind of have at it. But in general, it's people who are excited about stuff. And this stuff actually makes it feel more real, especially when they get a response from a human. They realize it's not just some mega corporate monolith doing this thing, it's people trying to do research, trying to get something helpful out into the world. And having stuff like this under the ad really increases its effectiveness, honestly. So there's kind of this flywheel effect where, oh, other people like this, that's cool, I'm into it too. And that's how we were able to kind of find 350 patients for this in 14 weeks, some of whom for sure would not have participated if they had to go to a site 10 times, because these are working moms in a lot of cases, and their life is already busy. So being able to do it from home with an app and remote visits was the thing that enabled their participation.
Yeah, that's great. That's great. Actually, just a couple more questions on this. I think there's just a lot of good stuff on here. So one, I think this question comes up a lot and in a lot of different context with adding technology to clinical trials, is the participation of 75 and over group. Is that a surprise? Is it a surprise to you guys running this that you saw over 20% come from that age group?
It's not for me, because we've had just a number of studies. We had one where 85 was the cutoff age and needs to be older than that, and it was one of our best recruitment efforts. And there's two things going on there, I think. One, a lot of other industries and advertisers just generally assume that elderly populations are not going to be super reachable via digital channels, and so they haven't shifted their strategy. So if you're willing to be one of the first people there, it's a less diluted environment. And two, in general, older internet users are less suspicious of ads, and so they'll click on them and engage them at a higher rate. And I think Kamala, you can speak to this, but generally compliance has been higher in older groups as well. We don't see that as much because we just deal with recruitment, but we know that engagement levels, meaning how much are they clicking, how often are they converting, and older populations are really strong. And I know that in the US at least, 75% of the population over the age of 65 is what we would call digitally addressable, meaning that they're using the internet every day, which I think is surprising to some folks.
Yeah, and I can kind of maybe pick it up where the study starts. So I saw a chat come in, the graphics just a little bit off. So it was actually 22% of the participants were over 65 years old, but our oldest patient on this study was 82. And Steve kind of alluded to this, but he was right. We actually did kind of a deep dive after the fact and looked into compliance. So the folks that were under 65 had a compliance of 88%, which is pretty good. But then when we're comparing them to their older counterparts, so 65 and older, they actually had a higher compliance percentage. They were at 91. So not only do older populations have access to this, have interest in this, I think there might be some misconceptions about how successful they can be on a decentralized study. And yeah, again, just a reminder, this one was on that spectrum on the fully virtual side. So no brick and mortar sites.
Yeah, very good. And I'm just, one other thing on this slide I was curious about is, I mean, as the cost reduction, I mean, I think this is important to people. You know, I think a massive reduction may not be possible on all studies, but just kind of curious, like, what are some of the big drivers when cost is removed from some of these studies when they're done right? Are we talking about sort of less oversight, or just they got enrolled faster? Obviously, that helps when trials enroll faster.
Are you speaking cost from the perspective of a sponsor?
10x lower costs. Just kind of what just.
So I think it kind of depends project to project. For this one, yeah. I do think overhead is a big one, right? The introduction of a brick and mortar site, the training, the resources that takes on is significantly larger than it is when you're talking about a virtual site team. So that's really, I think, what's at the root of that.
Yeah.
I imagine recruitment is another piece of it, though, Steve.
Yeah.
Yeah, so I mean,
we may not always have
that
big of a trade-off, but they are possible. Sorry, Steve, were you going to say something?
No, yeah, I'll just say it's case by case. And in this instance, I mean, again, if you're taking an audience and adding a 0 to it because you're now going national instead of just around certain sites, it absolutely drives speed. And that has two things. One, these ads become really efficient. Like you see all these comments, we're getting a lot of organic enrollments that we're not paying a dime for because someone is tagging their friend and pulling them into the study. And the other piece is that reduction in overhead. So if you had planned for 9 months of enrollment and it happens in 3, well, now all the timelines get bumped up by 6 months, and there's a lot of meters that we're going to be running for a few months that are no longer running. So the recruitment itself costs less, and then it can have downstream effects if it goes according to plan.
Yeah, cool. Thank you. Thank you. All right, why don't we move to the next slide here? And this is the last piece in the patient section, but just one more. Yep. So this is just something I wanted to add here is that, and this really adds to kind of what Steve and Kamali have mentioned, which is just around designing the technology aspect of it around sort of the consumer experience, what patients expect and what sites expect, and to not be just so hyper focused on the data and exactly what we want to come out at the end. And at least inside our company, we have people dedicated to this, to user experience, and we think a lot about kind of universal design principles for consumer products. And like some things that I always like is just when we design anything, to think about equitable use, make sure people with different ability levels to use technology are able to use everything that's added onto a study. And then I certainly think that that helps with diversity and in many different ways. Flexibility, you got to think about different use cases and different ways people are using the app, and some of that has to do with allowing for different languages and things like that. And just one of my favorite is just low physical effort. Just always thinking about like how do we give the least amount of steps for people to access the technology and use the technology. And again, that's important for patients and sites as well. Steve or Kamali, anything to add there? Or shall we move on?
I think we can move on. Totally agree with all of that, though.
Yeah. Okay. Yeah. So let's do. All right. So we're gonna move to the next section here, which is we've talked a little bit about reducing patient burden and thinking about the patient experience, but how does this reduction in burden transfer to study and site teams? How do we make their lives easier? Obviously, these are major stakeholders that we also can't ignore on these projects. So I'm going to start with Steve on this one as well. And how do you guys think about this?
Yeah, so I think there's a couple possibilities here. One is if you can use your kind of enrollment experience to kind of pre-screen and get people consented and out of the way in a decentralized fashion, there's a lot less burden on sites. If everyone who's showing up at the door is someone who's already in the study because they've been able to screen, or at least they're as far down the funnel as possible, that's just a lot less work that you have to do at the site level for people who ultimately won't end up on protocol. And it's not that they're like wasting your time, it's that maybe they just have a blood level that's inappropriate for the study and they're going to screen out. If they can get that stuff done ahead of time, that's really helpful. But also from the recruitment perspective, and this is maybe more of like a data thing that would be helpful for study teams rather than at the site level. But when you're recruiting fully digitally, you have access and control over the volume. So it's like a faucet. You can turn it up, you can turn it down. And so we've been in a number of situations where some sites have said, hey, we're at capacity, don't send us any more leads, and we can turn that down. Whereas if you just ran a TV ad in a city and your phones are ringing off the hook for 3 days, like there's nothing you can do but answer inbound. Whereas we can kind of turn that down, let you get your feet under you, and then ramp back up. The other thing is predictability. So we know pretty well like who lives in certain areas, and we have a really strong historical record of what engagement rates are going to be, click-through rates, and this stuff is all modeled pretty narrowly so that we can tell you with a relative degree of experience, like, hey, we're going to be sending you 20 to 30 leads per week who are pre-screened, pre-qualified. All you have to do is call them and set appointments. And if they say that's a little bit too much, or we can handle twice that many, we can make those adjustments. So I think from sites like this sense of predictability and this sense of, I'm not going to get any curveballs thrown at me from a recruitment perspective is really helpful.
I like that. That makes a lot of sense. Kamalia, how are you guys thinking about it?
Yeah, you kind of spoke to this before. I think for me, honestly, the first question, improving the patient experience is, as I work, my ultimate goal, but I do think a lot of the same improvements that we're making for the patient experience are the same on the clinical side. So thinking about reduction of burden, it's really in those kind of same places. So I mentioned before communication. I think that's a big one. Being able to really easily communicate with your patients. Based on some of the interactions I've had with sites, I actually think that can sound kind of daunting in the beginning. So the expectation of having to constantly be available to all of the patients on all of your studies. But we've actually seen it translate to something a little bit different. The majority of the time, it's just being there to answer a quick question about the study or a question about the responsibilities that the patient has. So realistically, opening those lines of communication, I think, allow questions to be answered pretty efficiently, sometimes even just through a chat without having to schedule an ad hoc visit or a phone call. So I think that's a big one. And I also think the introduction of devices is a big one. So I think we have a slide on this one. Remote patient monitoring in general, I think just reduces a patient's time in office. So again, that's a big one for the burden of the patient. But then by default, it also reduces the time for the clinician because they no longer have to take time to capture those readings. Patients are either wearing a device or taking a measurement themselves at home, and we can instead just flow that data right into the study database for them to monitor remotely. So just starting to pull away the number of site visits and the time in clinic, again, impact both the patient, I think, and the clinician. The graphic that we're seeing here is actually a COVID-19 study that we worked on recently. It was a study for symptomatic COVID patients who did not require hospital care, so outpatient. So obviously we didn't want to have these folks regularly traveling into the office as COVID positive. So we put together a suite of remote patient monitoring devices, and you'll see them here. There is the Bluetooth thermometer, Bluetooth pulse oximeter, and an at-home ECG device. So the way that worked is we took those devices, they were all synced to the patient's mobile device at the beginning of the study when they were on site, and then linked back to their study ID. And then as they were taking the readings at home, again, they just went into the study database, and the site staff could monitor those remotely. So obviously, huge advantage in terms of practicality and safety for the patient. But then given that this was a COVID study, it was also really beneficial to the sites because they could keep the site traffic at a minimum because they didn't have to conduct those readings on site. And this is maybe a little bit off script, a little bit less on the site burden, but I think worth mentioning that the introduction of at-home devices we found is also a huge benefit to the researcher or to the sponsor. I think we all realize this, but actually seeing the data is another thing. At-home devices really just generate an unbelievable amount of data. So instead of those point-in-time at-site readings, we're getting regular at-home readings, or in some cases, just continuous data. And that gives, one, for the clinicians, a more accurate picture of the study journey, how their patients are doing at home. But it also just gives us an access to just an immense volume of data that I don't think could be captured or collected at a traditional site.
That's great. That's very good. Yeah. A couple things I'll add just to the to the clinical. So at least the site perspective. Number one is that I think there are a lot of benefits, but there are also this is new vendors, new processes that a lot of sites are having to deal with and having to figure out, and it really is on us as providers to make sure that, number one, we got to make sure the stuff works and doesn't provide a troubleshooting burden on them, but also that we are training and supporting sites as much as possible. I know, Kamala, you mentioned we're not expecting to be on the phone every day with people, but just to be there and be able to solve things when needed. But I think when they do get implemented correctly, there are big benefits. There are More predictable enrollment, as Steve mentioned, does make life easier for sites and makes life easier for sponsors, of course. And you can kind of widen that geographic range. Even if you're still working with brick and mortar sites, people are going to be willing to travel a little bit further if they don't have to go in as much. And if you can get more patients into fewer sites, that's better for sponsors, CROs. That's better for the sites as well. And so I think, and one final thing is a lot of what we've talked about so far has been kind of newer ways of data capture that is more e-source and less write something down and transcribe it into an EDC. And so that also, removal of that process means less work for everybody, and kind of a reduction in administrative burden. So I think those things are great, but also just want to acknowledge this isn't without its challenges, and we all have to be aware going in. Got to make sure everybody's supported properly and as they're adopting some of these ways of working.
Yeah, I think you touched on a really important one there, which is the training piece. There are systems that every site is used to, and introducing a new one, even if it's a lot simpler from our perspective, it's still an entirely new system to learn. So really making sure that you're thinking about training at the site level is so important. Yeah.
Just being appreciative that this is not the second system too they're using. It's like the seventh. And so just kind of being conscious of that's important. Okay. So moving on, this is the third of three kind of major sections we have here. And just sort of thinking about as you're putting together this process of kind of how are we going to flow from we're making the study, we're kind of raising study awareness out in the world all the way through patients coming through the study to completion. How do we think about interoperability, kind of making sure that systems and processes are connected? There's sometimes quite a few more stakeholders than there were in the way we were running fully traditional studies. So I think, Kamali, I'll start with you on this one. How do you think about picking the right tools and processes to make sure that things are streamlined and integrated in the way that they need to be?
Yeah, and I might have actually thought about this question a little bit differently necessarily than the interoperability piece. I was more just thinking about kind of lessons learned, of which we've had a lot over the last 5 years. I think we've all kind of touched on this, but this is a super innovative space. And I think it's safe to say that we're not all going to get it perfect right out of the gate. So I was kind of approaching this in best practices as far as how how as a team we try to approach new study designs, new technologies, that kind of thing.
Perfect. That's great. Yeah.
So I think the big one I was thinking about, which we just touched on, which is great, we kind of got there naturally, was training. And not just training at the site. I think training for the patient is super important. We have the graphic there. So for me, I can build, and I do work on the actual screen structure as well with our design team, but we can build as a group what we think is like the easiest to use, most straightforward EPRO tool, but it doesn't always mean that it'll be received that way. I think we all look at and consume information very differently, and training is a good equalizer. I think it's a good way to ensure that patients are not only clear on their study responsibilities, but super clear on how they're expected to interact with the technology. So providing training that's easy to understand, easily accessible for patients. I think those are the things that make the patient journey easier. And so kind of streamlines that process, something we keep in mind as we're starting to put together our technologies, so to speak. And this metric kind of speaks to that as well. So we're seeing significant increases across the board here in the post-training accuracy, one tool even showing greater than a 30% increase in accuracy after training. So really not just assuming that you're making something super straightforward, but making sure that you're also supporting that with training that kind of walks the patient through how they're supposed to interact with it. So that was one of them. Another really big one for me, I'm realizing now as we were talking through, we all kind of touched on each of these, but I think another really big one is designing with the user in mind. You were speaking to that about creating ePRO. I think it's really important that we're not just thinking about study design optimization from a research perspective, but thinking about it from the perspective of patients. So I mentioned that COVID-19 study earlier that we did recently, our suite of devices. We actually started out with more than 3 devices. So we had this full suite that we thought would be most appropriate to take measurements that were applicable to folks with COVID. We launched the study and we kind of realized we were hitting a wall, both from patients and sites, on the volume of devices and the added burden that came with that. So there we were thinking we were actually reducing burden and generating more data. But in reality, it was just too much for the patients to take on, especially given that they had COVID. So on the plus side there, we were pretty quickly able to identify the root cause, but what it told us was that we had missed the mark a little bit. So we did a rehuddle with a sponsor. We looked at like what measurements we really needed to capture towards their endpoints, and we were able to streamline it down to those devices, those 3 devices we showed earlier. And I think that smaller group of devices, it did streamline things. It still gave us the volume of data that we needed for the study, a volume of data, again, that I don't think could have just been collected at the site. But had we taken that moment to design with the user in mind, we might have realized these are people that aren't feeling great. Let's look at just the bare minimum of what we can capture, those like non-negotiable measurements, and then say, all right, let's not put any more responsibility on that patient. So that's kind of the second best practice for me, is really thinking about the user when we're talking about study design, but also technology design. And then I'd say the last one, I'm just going to keep going. The last one, and probably the biggest one for me, less of a best practice, more just I think a guiding principle, is the human component. So yes, we have access to all these really great, amazing technologies, but it's really important to not lose sight of the human component in all of this. I joined this industry obviously without any of the technology pieces at play, but as cheesy as it sounds, I really did join to make a difference in a person's life and people's lives in any way that I could. So getting wrapped up in the technology is something that I try and pull myself out of. So less important to have the most innovative project, but more important to think about how to utilize technology to help patients feel supported, help them feel more connected, things like that. And I think a big one that I've realized over the last few years is investing time in those communication technologies. So I think the pandemic pushed us in that telehealth direction. And I think that's a space we can continue to expand on in clinical research. I think we already have. We've made huge changes over the last few years, but just continuing to utilize that to make sure we don't lose sight of that human connection piece. And then also just kind of bringing it back to what you said before, what I said before, the user experience is just hugely important. So just making sure that we're all creating tools that really do reduce patient burden and aren't just cool new technologies.
Yeah, that's great. And I really like the bit about kind of not losing sight of the human connection. As we worked with a couple of our CRO partners that made that very clear, that like this isn't the bots taking over clinical research or anything like that. There's still, even if we're using different ways of using technology, there's always a caring individual and patients involved. There's a caregiver providing the care and patients involved, and anything we can do to make that connection deeper is great, but that's got to be kind of the center of it. So
totally
yeah, thanks for pointing that out.
Yeah, I think technology is something that we can use to enhance it instead of replace it.
Yeah, exactly. Steve, what are you guys doing in the patient recruitment engagement realm to sort of help with this topic?
So I mean, I have a patchwork of thoughts here. I'll just give 3 of them. So the first is, I think the best way to create a streamlined experience for patients is to automate everything so that they can take their next step as soon as possible, because the time someone is ready to take their next step is right after they just took their first step. But giving ample and almost limitless off-roads to human contact whenever and wherever they want it. So this might look like an online pre-screener that goes into a chat bot for follow-up and scheduling with automated everything, so that the first time they talk to a person is a telehealth screening visit on a fully remote study, or the first time they talk to a person is walking in the door of the clinic on a regular visit. But if they want to get out of that and they have a question, that is fully accessible to them, because a lot of people just want to do things at their own pace, and that will rapidly increase the amount of conversion and the amount of people who are able to do their thing. But then some people want their hands held. So for me, it's allowing them to move as quickly as they want to, while providing optionality for people who have questions and want a little bit more personalized care along the way. So that's the biggest thing for us that we're doing. I mean, recruitment stops really early in the process. So that's really our biggest insight. But I want to say this from a conference I just attended. I feel like there's a potential like land war brewing between sites and sponsors. I heard at the same conference on the same day at two different panels, a sponsor saying to the question, what do you do if sites don't want to use the technology you've selected for a study? And the sponsor said, frankly, we would skip them and use a different site. And then a site network who said the same thing to a similar question basically said, we are going to stick to our guns, and if you're going to make us use extra technology, we're going to bill you for the training, we're going to bill you for any double work where we have to input it into two systems, we're going to bill you, because it is extra work and it is extra burden, and it does reduce the efficiencies that they've gained over time learning the systems that they've chosen to deploy. So I fear that something is coming to a head, and for everyone, I guess the interoperability question is, if you're building tech right now, figure out how to make it play nice with as many systems as possible, or you might be left out in the cold. And if you're a sponsor, instead of going to the store and like picking the best thing on every shelf, figure out how those things work together before you finalize your protocol and then roll it out to sites and they have to learn 7 new systems. I don't know, I see you nodding, you've got your head in your hands. I don't know if I've just said something horrible, but I'll take a break.
No, not at all. No, these are all things we're all dealing with for sure. It's interesting. And did you have anything else, Steve?
I have one last thing, and this is a bit slightly off topic, but we've kind of alluded to this idea that if you open up recruitment to everyone, you can find who you need, even the diversity components. And I want to say that that is extremely true with a caveat. I'm going to go into marketing nerd for like 30 seconds, bear with me. The way these platforms work, Facebook, Instagram, YouTube, Google, whatever, they are tracking who converts on the site. So someone who comes and fills out their information and hits submit and qualifies for the study. They've raised their hand, I want to participate. They pass the pre-screener logic, hooray. That gets fed back to the advertising platforms, and the algorithm says, find more people like this. So we know that about 85% of study participants are white folks in North America. So what's happening is there's a feedback loop that is saying, all right, there's white people in the door, let's go find more of them. So to ensure that we're finding diverse populations, we actually have to break the algorithms and override that system and say, no, don't find more people who look like this. Even though they're converting, we don't want to be the most efficient we can be. We want to be the most representative we can be. So stop finding people like this and look for people like this. That has an impact on budgets, right? If I tell this efficient system to operate less efficiently, it's going to cost more. And so the bottom line for sponsors is if they want to fill their diversity requirements using DCTs, they absolutely can. These metrics are real time, and adjustments can be made within the hour to which budgets are being raised and decreased. But there is a real cost associated with trying to find people who do not naturally gravitate towards clinical research. So I know that's not totally in play, but I know there's a lot of like, hey, DCTs are a panacea and they're going to cure a lot of things. And I think in some ways they can, but there's a very real just financial cost to operating with what these algorithms would consider to be inefficiency.
That's great. Appreciate that. I think then I'll just kind of move. The last thing I wanted to add here is it really around just kind of big picture, looking at all the systems and tools that we're bringing in. There's, I think I mentioned earlier, there's data is collected from a lot more sources, and this isn't only for decentralized trials. There's just new pieces of technology put on a lot of trials, but as you start to do that, I think there's sometimes an instinct to say, let's just try these out. Let's not do, let's see if we can see how things go the first time. And then if we like the way things went, then let's put a lot more time kind of down the road into a full integration and really make all these things sing together. I think I'd just like to argue it's worth thinking about doing that the first time to make sure things go well. I think there's sometimes an unanticipated amount of manual work that has to be done that can really bog trials down. And if you spend the right time finding interoperable technology and doing the integrations ahead of time and just figuring out what metrics do you need to run your study, if patients are sometimes being seen in the home, how is data being collected there, sometimes being seen in the clinic, it might be collected slightly different. If you make sure that's all mapped together, you're probably going to see it worth your while in the very first study. And so that can also it can be a little daunting. It's something new, but it's an important consideration. And I think that's it for the scheduled content here. We do have a little bit of time for Q&A, so please, if anybody hasn't already, if you've got something you want to drop into the chat, please do so. We'd be happy to answer. But I can take a look and see what we've got so far. Give me a quick second here. And I see one question here around eConsent. And I think maybe Kamalia, if you want to start on this one, and I can perhaps add a little too, but what measures do you guys take in the eConsent process to make sure that the participant is able to read the material, has read and understand the material, and also is the actual participant and there's no kind of identity issues going on?
There were a lot of pieces in that one, I think. So maybe I'll take
Any
a part
of them
and
are
pass
good.
it back to you. Yeah. So for us, as we build out technology to support eConsent, and I was actually on a call about this morning, we build around the principle that consent is not a signature. It's not like a point in time step. It's a process. So I think kind of the latter half of that on the regulatory side, there's a ton that needs to be in place to ensure compliance from a technical perspective, validating that an individual is who they say they are. But really kind of taking it back to the technology side of things, I think it's most important to make sure that you're doing what you can to ensure that the patient really knows what they're signing up for. Like that's a really important part of consent. So that's what we try and use the technology for. And I think that's twofold. So really kind of first and foremost, again, this is a recurring theme of our conversation. I think it's tapping on the study team. So consent is a part of a study that I think is so tied to that human connection.
Mm-hmm.
So just again, really making sure that communication between a potential patient and the site staff is as easy as possible. And I think that can mean a range of things. It can be as simple as providing easy access to a chat. So you can quickly ask, I have a question about this line of the consent, or scheduling a full telehealth visit into the study journey to make sure that you're walking each patient through all of the pieces of the consent themselves. So then either way, really ensuring that the patient is able to get all their questions answered before they they agree to continue. I think that's probably the biggest one, but I also think taking the human component out, there's a lot to do on the technology side to create the right experience for a patient. And so things that make it more interactive, using multimedia, using quizzes, those are things that help solidify patient understanding, but also give us insight to ensure that we're doing our due diligence to make sure that the consent process is being properly conducted. And then the last one, I think, isn't necessarily something that just DCTs struggle with, but in general, the consent document, and I've written many, it's a beast of a document, right? There's like a ton of dense text, and rarely do you find, I think, patients that are very much interested in going line by line and digging in. And I think if we, from the technology side, think about ways that we can break that down into bite-sized pieces for patients, make it more engaging, make it easier to consume, we put the patients in a way better position to really understand what they're consenting to. So again, they know what they're saying yes to when they sign the consent at the end of this process. But I think by default, that also puts the study in a better position to be successful, because the patients that are coming on board do have a clear picture of what they're supposed to do and when they're supposed to do it.
That's great. Yep. So, Jack, I see you are saying, so we have a follow-up to this in the Q&A section. Let us know. Sorry for the technical wonkiness here, but
they're just asking about training specifically.
What's that?
So they're asking if patient training is really important, what optionality do we have for training these patients?
Got it.
I'm not sure I'm clear on that one.
I think it's sort of along the line of some patients may respond better to different things. Maybe some patients having just enabling that face-to-face chat with the site staff, making sure that's available. And then some people want to have not just a dense legalese type document, but something that's, I want in plain English, of course, but that's just consent design. But then there's also having sort of other media in there, having quizzes in there to reinforce understanding. I mean, all these kind of things I think are what figuring out what's best, and maybe even providing optionality for each study, I think is along the lines of what that question is getting at. Do you have anything else to add on there?
No, I think the answer to the question is kind of built into the question. It's giving options. Everybody does really do this differently. There are plenty of people, I think, that we've seen that just they're interested in understanding, but they have a general idea, and reading through the consent is not something that they're interested in. So for them, they might have a quick question that they want to get answered. Making that easy is super important. That's one path. On the flip side, making sure that there is a full call scheduled when it is something that we want to walk through step by step with a patient. Those are different options about how engaged you want to force the patient to be, but understanding that ideally you're giving them all the options to choose from. You're allowing them to proceed in a way that they're comfortable with.
Good, that's great. So I see another question in here that I think is perfect for Steve, and it's about the recent changes to the way that Facebook advertising targeting works. Have you seen any impact on the way that you guys run your business and the way that you create, the way that you manage advertising campaigns because of this?
So I'll give a yes and no answer. So yes, on the surface, like no more targeting by health state makes it difficult. So well, you could never target by health state. So let's get that out front. Like there was never a box that like, hey, find people with breast cancer. But previously, you could target people if they liked Susan G. Komen Foundation, and maybe that was a proxy. But we've kind of built One in Health, at least, knowing that even that is full of errors, right? There's plenty of people who like Susan G. Komen because they're supporting a friend, not because they themselves have it. And there's lots of people who have breast cancer who never bothered to check the like button on Susan G. Komen. So I think all this means is you have to be a little bit more thoughtful and a little bit more intentional about how you're building targeting campaigns. And maybe that means you just start with a broad audience and you let, kind of what I was talking about earlier, people who come through the funnel, you let that kind of feed back and then refine the audience along the way. Maybe it means you try different multi-channel approaches. So we've had shockingly great results finding patients over the age of 65 to participate in colonoscopy screening on TikTok, despite the fact that it is the platform of the youths. So I think it really just comes down to, one, Facebook is a great advertising product. I will be honest, it's fantastic. But it's not the only one out there in the world, and there are ways to connect with your audience using variables that still are in play. So you can still target by what people listen to, what they buy, what they do for fun. So figuring out, like, are there proxies that would help me get in front of the right relevant patient group? So it's made it slightly more difficult, but I don't think that it is overall impacted. And the numbers are still going up. According to all the people who are researching this, social media and online advertising is the #1 way people are finding about clinical research opportunities right now. And I don't anticipate that going down anytime soon.
Very good. It looks like there are no more questions. And if not, happy to wrap up 3 minutes early. We're probably running out of time for another one anyway. So we can just wrap up, and I'll say thank you so much, Steve and Kamalia. It's been great. Thanks for everybody who's joined. Hope everyone found this informative and enjoyed the hour. So thanks everybody. We can close it up.
Thanks, everyone.
Thanks, Andy. Cheers, everyone.
See you.
Bye.